Gender-specific differences in cardiovascular health are influenced by a combination of biological, hormonal, and behavioral factors. These differences affect the prevalence, presentation, treatment, and outcomes of cardiovascular disease, which is CVD, in men and women. First, biological differences. Heart size and structure. On average, women have smaller hearts and thinner coronary arteries than men. This can affect the symptom, progression, and treatment outcomes of the heart diseases. The other one, blood pressure regulation. Men are more prone to higher systolic blood pressure at an earlier age, while women experience a significant rise in blood pressure post-menopause. About hormonal influence, estrogen in women. Estrogen in women acts as a protective role, which is before menopause. Estrogen helps maintain the flexibility of blood vessels and regulates cholesterol, reducing the risk of atherosclerosis. Post-menopause risk. After menopause, estrogen levels drop, leading to increased LDL, which is the bad cholesterol, and decreased HDL, which is the good cholesterol, raising the risk of cardiovascular diseases. While testosterone in men, may offer some cardiovascular benefits. High levels are associated with increased risk of hypertension, cholesterol issues, and metabolic syndrome. The third is differences in disease prevalence. Coronary artery diseases, which is CAD, more common in men than women, especially before women reach menopause. In women, CAD often manifests after in life but can be more severe. Heart failure. Men are more likely to experience heart failure with reduced ejection fraction, which is HFrEF. Women are more prone to heart failure with preserved ejection fraction, which is HFpEF, often linked to hypertension and diastolic dysfunction. While hypertension affects men more commonly before age 65, after menopause, women surpass men in prevalence. Arterial fibrillation. Women with arterial fibrillation have higher risk of stroke compared to men.
I will continue this presentation and explain how risk factors for cardiovascular disease or CVDs differ between males and females. We categorize these factors into two groups, non-modifiable and modifiable. So let's start with the non-modifiable factors, which are those we cannot change. The first one is age. Males face a higher risk of CVD earlier in life because of the condition like atherosclerosis. The buildup of plaque in the arteries tend to develop sooner. The second point is about gender. Men are more prone to coronary artery disease (CAD) earlier in life, driven by the influence of testosterone and certain lifestyle factors. However, women are more likely to develop heart failure, which means their heart pumps normally but does not fill properly. Women also experience atypical symptoms like fatigue or nausea, which can delay diagnosis. Now, let's move to the modifiable factors, which are risks we can change through lifestyle and behavior. So first, lifestyle factors. In females, postmenopausal diets that are low in protective nutrients like phytoestrogens can worsen cardiovascular risk. In contrast, males tend to consume more red meats and processed food, which increase cholesterol levels and contribute to heart disease. But last but not least is obesity. So obesity impacts both genders but in slightly different ways. In females, central obesity, it is weight gain around the abdomen, become a significant driver of CVD risk, especially after menopause. But in contrast, for males, the focus is on the visceral fat accumulation which surround internal organs. Visceral fat is metabolically active and worsens cardiovascular risk by increasing inflammation and insulin resistance.
So today I want to tell you about hormonal influence in cardiovascular health. So we start with estrogen and progesterone in female. Estrogen provides cardiovascular protection during reproduction, hereby promoting vasodilation, regulating lipid metabolism, reducing inflammation and vascular stiffness. Postmenopause is the decline in estrogen lead to increased risk of hypertension and myocardial infarction. Progesterone is modulate vascular tone and fluid retention, influencing blood pressure and risk of pregnancy-related complications such as preeclampsia. So we continue with testosterone in male. At psychological level, it promotes cardiac output and support muscle mass. At elevated level, it increases atherosclerosis risk by raising LDL cholesterol and reducing HDL cholesterol. Men experience highest rate of ischemic heart disease (IHD) at younger age compared to female. So we continue with lifestyle factor. The first one is dietary habit. For male, first one is higher caloric intake. Men tend to consume more calories often due to highest energy need. However, this can also lead to overconsumption of unhealthy food. Second one is preference for saturated fat. Men are more likely to consume diet rich in red meat, processed food, and saturated fat, which increase LDL cholesterol level, leading to highest risks of atherosclerosis and coronary artery disease. For female, is better dietary choice. Female typically consume more fruit, vegetable, and whole grain, which are associated with improved cardiovascular health due to their anti-inflammatory and antioxidant properties. The last one is emphasis on weight control. Female are more likely to adopt a strict diet to manage body weight, which, if extreme, it may lead to nutrient deficiencies and impair heart function. Next, we move to smoking and alcohol consumption. Smokers are more likely to present with earlier onset of CVD, and the disease may be more advanced at the diagnosis. Symptoms of CVD is smoker may include chest pain, shortness of breath, fatigue, and irregular heartbeat, often manifesting earlier than in non-smoker. Alcohol consumption. A heavy drinker often present with alcohol-related CVD such as hypertension or cardiomyopathy, and the presentation may include severe fatigue, edema, or shortness of breath.
Genetic variations significantly influence the development of cardiovascular disease, and these risks vary between men and women due to biological and hormonal factors. For instance, women are more prone to arrhythmias such as long QT syndrome, which can be attributed to hormonal influences and genetic variations in ion channel function. Men, on the other hand, have a higher risk of coronary artery disease, often tied to genetic differences affecting lipid metabolism and plaque formation in arteries. Furthermore, gene-environment interactions such as the interplay between genetic predispositions and lifestyle factors like smoking, diet, and physical activity can amplify this risk in a gender-specific manner. For example, men with genetic tendencies toward higher cholesterol may see greater risk from poor diet, while women with ion channel mutations may be more affected by hormonal changes during pregnancy or menopause. These interactions underline the complexity of CVD risk factors across genders. Variations in cardiovascular outcomes between males and females result from a complex interplay of hormonal, lifestyle, and genetic factors. Hormones play a key role, with estrogen providing cardioprotection in premenopausal women by improving vascular health and regulating lipid profiles. However, after menopause, the loss of estrogen leads to increased risk of atherosclerosis and hypertension. In men, testosterone influences lipid profiles by raising LDL and lowering HDL cholesterol levels, contributing to a higher risk of coronary artery disease. Lifestyle factors also contribute to these differences. Men's higher consumption of red meat and lower adherence to balanced diets contribute to elevated cholesterol levels, while women's healthier eating habits offer some protection, although this advantage diminishes post-menopause. Additionally, men have historically exhibited higher smoking and alcohol consumption rate, which significantly elevate CVD risk. On the other hand, women's heightened response to emotional stress increase their susceptibility to stress-induced cardiomyopathy. Genetics further explains gender-specific outcomes. Women are more prone to arrhythmias like long QT syndromes, often linked to ion channel gene mutation and hormonal change. Men, however, have a higher prevalence of coronary artery disease, driven by genetic differences in lipid metabolism and plaque formation. Gene-environment interactions, such as the influence of diet or smoking on genetic predispositions, exacerbate this risk differently in men and women. These combined factors result in distinct cardiovascular outcomes. Women are more likely to experience microvascular disease, arrhythmias, and stress-related cardiac conditions, while men face higher risks of coronary artery blockage and an earlier onset of cardiovascular disease. Understanding these variations is essential for developing tailored prevention and treatment strategies.
To continue the presentation, I will discuss topics that involve both chart and table related to an article that record data from 2010 to 2019. So let's dive into the first topic. Here we can see the gender difference in cardiovascular disease or CDV incidence over age group. In the chart above, there's two different type of color line that represent both genders. So for men, the risk starts increasing significantly in their 40s and peaks around their 60s. But for women, the risk remains relatively lower until the post-menopause, where it accelerates and eventually surpasses men in older age group. So the second topic is about the gender comparison of survival rates and diagnostic delays. The table above illustrates two critical disparities in cardiovascular outcome between genders. The first one, women experience an average diagnostic delay of 6.7 hours compared to 4.5 hours in men. This delay is primarily due to atypical symptom presentation in women, such as fatigue, nausea, which differ from the classic chest pain typically seen in men. So the second one is the survival rates also reflect this disparity. 1 year after a heart attack, men have a survival rate of 78%, while women trade at 17%, partially due to these diagnostic delays and less timely treatment.
In conclusion, cardiovascular health is influenced by a combination of hormonal, lifestyles, and genetic factors that vary between genders. For example, hormonal differences like estrogen protective effects in women play a significant role in reducing cardiovascular risk until menopause. On the other hand, men may experience risk earlier due to the difference in hormone levels and lifestyle factors such as higher rates of smoking or alcohol use. Genetic predispositions also interact uniquely with the gender, shaping how cardiovascular conditions manifest. Recognizing this difference early allows for tailored screenings and treatment, which can significantly improve patients' outcome. Moreover, advancing research on gender-specific cardiovascular health is essential. Future studies should explore more these factors interact to develop personalized medical interventions. For instance, prevention strategies could include addressing lifestyle habits specific to women and men, designing medications tailored to the unique physiological response to each gender. These steps are crucial for closing gaps in diagnosis, treatment, and prevention. Ultimately, understanding and addressing gender-specific difference is not just about advising science, it's about making a meaningful impact on life. By embracing these distinctions in healthcare, we can save more lives, reduce disparities, and move towards to futures where everyone receives care that aligns with their individual needs.